Welcome to the Metastasis Research Society, METAvivor, and the Sentinel Node Foundation webinar panel to discuss stage 4 metastatic breast cancer from the patient perspective. A little bit of information about the program. I'm sure a lot of you have read about this, but the Metastasis Research Society, in collaboration with METAvivor, wrote for and received an award from the Patient-Centered Outcome Research Institute, or PCORI, to develop a program that would engage patients in the research and clinical areas of metastatic breast cancer. And it was basically to engage all of the stakeholders, but with a focus on patients. So we're starting, this is one of 3 webinars that we will be hosting over the next 3 months. This information will culminate in a survey that we're going to ask you and all of our stakeholders to complete, a simple 4-question survey that will be pretty exceptional, as it's the first time that we'll be discussing research priorities for metastatic breast cancer. All these activities will culminate in a conference on June 22nd and 23rd at Moffitt Cancer Center that will include patients, clinicians, and researchers in a forum where we will outline both clinical effectiveness research as well as translational research priorities. Though these items will be published as part of the research priorities for metastatic breast cancer and metastatic cancer as a whole. So you are on the cutting edge of metastatic breast cancer research. And I'm going to just ask Kate Bankaitis, who is with the Metastasis Research Society, to say a few words, and then we'll get started with the program.
Thanks, Sonia. You can just go ahead and put the webinar slide up. So just real briefly, everyone, my name is Kate. I'm with the Metastasis Research Society. As Sonia already mentioned, we have partnered together with METAvivor, so we have researchers, patients, and we've also partnered with the Sentinel Node Oncology Foundation to have more clinicians represented. Our goal is to work all together, engage with each other to help identify barriers to engagement and also come up with research priority topics for metastatic breast cancer from all perspectives so that we can be sure to get feasible and also patient-desired approaches and research and studies planned. So as Sonia mentioned, we have actually 3 of these webinars. The first is the one we're in now, understanding the patient perspective. Again, we'll have another one from researchers and a third from clinicians. I have just sent all attendees in the chat bar a link to the website where you can view the whole project and register for this. But the goal of the webinars is for us to better understand each group so that we can better understand and engage with each other in designing these research topics, which, next slide, Sonia. As she mentioned, will be discussed further at our engagement conference. And I just want to highlight, this is not your typical metastatic breast cancer conference. There is going to be some presentation of research, cutting edge research and treatments and material of that nature, but much of the time is going to be spent in roundtable working groups where clinicians, researchers, and patients will be working together to actually help solidify a finalized list of research priorities that METAvivor can consider actually for funding in 2018. The plan is to fund $2 million or more in metastatic breast cancer grants. So your voice really matters in voicing your opinion and what the top research priorities are from each perspective, whether you're a patient, clinician, or researcher. Please do fill out the survey that will be sent to you all today that allows you to start putting in which topics you feel are most important that we can collect votes on. Okay.
And I'll be sending that survey into your chat inbox inside the webinar program now. You can just click on the link and complete that short 4-question survey.
Perfect. Okay. I think you can hit the next slide, Sonia.
First, I would like to introduce our first patient panelist, Kelly Shanahan. She is a retired physician, a wife, a mother, a daughter, a doctor, all living with MBC, and we are just really pleased to have her aboard. She's a fierce patient advocate, and I'm going to turn it over to Kelly to get started.
Thank you very much. Next slide, please, Sonia. So just briefly, as Sonia already mentioned, I was an OBGYN in private practice. In 2008, my office manager scheduled me for a mammo because I hadn't had one in 2 years. And on that mammogram, I had an obvious breast cancer. And it would have actually been present 2 years before and had been missed. I had surgery. I live in Lake Tahoe, California, relatively small community with just a small hospital. Without all the services, and I went to UC San Francisco for my surgery. I chose to have bilateral mastectomy because as a busy OBGYN in solo private practice with a 9-year-old daughter, I didn't have time to drive 45 minutes each way to the nearest radiation oncology facility had I chosen a lumpectomy. My husband's not in the medical field. I recorded on an old-fashioned dictaphone a question for him to ask the surgeon, and the question was, what's the node? What's the Sentinel node? And I told my husband to hit record when the surgeon started speaking. I had a positive node, one positive node, which bought me the usual AC plus T chemotherapy regimen. I was back in my office within 2 weeks of my bilateral mastectomy. I was doing surgery again with a general surgeon scrubbing with me just in case. Within 4 weeks of my surgery, I did not miss one day of work due to my cancer diagnosis. My 9-year-old daughter asked me at the time, she said, when I told her I had cancer, her questions were, Mommy, are you going to die? And I said that, yeah, I was going to die, and the dog was going to die, and the cat was going to die, and we're all going to die, but I was not going to die from breast cancer because I was going to kick its ass. Well, I had to pay her $0.25 for saying the A word. And then I went about my merry little way, went back to work, really did not think about breast cancer again once I finished treatment. I was placed on an aromatase inhibitor, which I did not complete the full 5 years because the arthritis type symptoms in my hands was making it very difficult for me to do surgery. Fast forward 5 years, I developed some back pain. It happened when I was walking up the stairs and I sneezed violently, immediately had back pain, and my first thought was I'd pulled a muscle. When it didn't improve and it started getting worse, I'm like, I was 53, maybe I herniated a disc. Actually, I was 52. Maybe I herniated a disc. But I was busy, I didn't have time to deal with it. So I went on, my very busy, merry way. Ironically, I subleased my office. I owned my own building. I subleased my office one day a week to an oncologist. He saw me limping one day and he was like, Kelly, you've had cancer. You need scans. And I'm like, yeah, herniated disc. But he got me thinking and I scheduled an MRI and a PET scan. The people at the outpatient radiology facility who knew me because I sent all my patients there for ultrasounds and mammos, just wouldn't let me be the ordering physician on myself for some strange reason. And then I gave the oncologist's name. And because I was a doctor, I ordered the typical MRI of my lumbar spine, and what the heck, let's do a PET scan. I had the scans done on my birthday because when I scheduled stuff 2 months out, that was 2 months before I had a day that wasn't already booked. And I figured if I was going to close my office for the day, might as well close it on my birthday, and I'd have the scans and I'd go shopping and I'd get a manicure, and I'd come home and I'd have dinner with my family. I had the MRI, followed immediately by the PET scan, and I went out to my car to go get something to eat and then go back upstairs to go over the films with the radiologist. And there was a voicemail from the oncologist saying, "Kelly, call me." And I immediately knew that I had metastatic cancer. I also had a lesion in my femur that was about to erode through the bone and cause my leg to break. The back pain was from a fractured vertebrae. So 6 days after diagnosis, I had a rod put in my left femur. The pathology from the bone marrow reamings and from some lesions that the orthopedic surgeon saw and curetted on my bone confirmed that I had the same subtype that I had originally. I had ER/PR positive, HER2 negative, metastatic breast cancer. My PET scan lit up like a Christmas tree from my jaw through every single vertebrae, sternum, couple lesions in the pelvis, the about to break left femur. And I could no longer tell my daughter that I was going to kick breast cancer's ass because it was going to get me. The oncologist came up with a rather unconventional treatment recommendation. I knew the NCCN guidelines. I looked them up. I knew with the ER-positive bone mets that an aromatase inhibitor would be the recommended therapy. And when that failed, we'd move on to a second and then to a third. But the oncologist had a very compelling argument, and he said, these therapies are designed to slow progression, and I don't want to just slow progression. I would like to cause regression. And he recommended combination IV chemo to consist of a planned number of courses of combo A, which in my particular case was Cytoxan and a taxane, followed by a planned number of courses of combo B, which turned out to be 5FU and I'm having chemo brain, and I forget what the second one was. Then going on an aromatase inhibitor. I didn't question it. I did ask him, one of my first questions was, what about a clinical trial? And he poo-pooed the idea of a clinical trial. I live 4 hours away from San Francisco, which is the nearest place doing a significant amount of metastatic breast cancer research. I was diagnosed on November 14th. My daughter was in a play. She was 15. She didn't drive. She had rehearsals. I was still working, sort of, after the diagnosis. And it was winter in Tahoe, in a ski resort town where sometimes there's not the ability to get off the mountain. So I listened to my oncologist, and I chose to go with the IV chemo. I did 14 months of IV chemo, followed by my current treatment, which is an aromatase inhibitor. And because of the bone mets, I was also on either Zometa or Xeloda for a total of 2 years. Currently just on exemestane, aromasin. And I am very lucky. I am, 6 weeks away from my 4-year metaversary. And I have remained with no evidence of active disease for 44 of the soon-to-be 48 months. So I am extremely lucky. Next slide, please, Sonia. Next slide. So I think one of the things we need to discuss before we even discuss research priorities in terms of what should be researched is trial design. I strongly believe that there needs to be patient and advocate participation in design from conception to completion. By having advocates and patients involved from the first idea that the researchers have about, man, it would be a great idea. I think it'd be a great idea to do a trial on this. I think we're going to get a lot of benefits. We're going to be able, I believe, to have increased and faster enrollment with patient engagement, because we can speak to our constituents. And if we're excited about a trial, we can get them excited about a trial. I also think that the consent forms need to be vetted by the advocates, and they need to be understandable to the average patient. my patients always told me that I was really good at translating doctor speak, medicalese into plain English. And I think clinical trials need to do that as well. When there's a 40-page consent form, patients are going to zone out, especially patients that, not every patient is going to have an MD or a PhD after their name. I think having advocates available to mentor participants is also important. We can help allay fears, and someone who's experienced in a clinical trial may help allay the fears of someone participating in their first trial. And I also think that there need to be endpoints that are meaningful to the patient. There's been a lot of discussion about this. The Metastatic Breast Cancer Alliance has recently done some work and published on this. But, things that may be important to researchers, super interesting scientific questions, the patients don't necessarily care about. We care about, will I be here for my kid's graduation? That is my one and only concern right now, is am I going to make it until May of 2020 when my daughter graduates from college? Next slide, please. So the other thing is, it is 2017, soon to be 2018. If Amazon knows what I want when I log onto their website, and if they can get something to me in South Lake Tahoe in 24 hours, why are our trials tied to brick and mortar institutions housed only at major cancer centers? There are ways to increase participation, get a more geographically diverse study population, if we allow some of the basics to be done at the patient's home oncology center. I do understand that there are problems with IRB approval, but I think we have Scott Gottlieb now at the FDA, who wants to get things done more quickly, where my local oncologist could work with a research center so that I can participate in a trial without having to drive 4 hours each way every few weeks. I also think that the washout period of 28 days that most trials require is a huge, huge barrier. This is not what happens in the real world. And the real world, there's a treatment failure and you are immediately placed on a new treatment. In the case of oral medication, it literally is immediate. In the case of IV chemo, there might be a delay of 1 to 2 weeks, just like there'd be a 1 to 2 week gap in any treatment protocol. So we need to do these things. And we can do these things. And yes, they're hard, but they can be done. In terms of research priority itself, I think looking at genomically driven combinatorial treatments makes sense. Precision medicine, personalized medicine, being able to look at what mutations a patient has, either circulating tumor cells and cell-free DNA, or if there's an accessible site of metastases or progression that can be easily and safely biopsied. We're going to get to get a better understanding of what will and what will not work in a given patient. I think combination potentially can decrease development of resistance by targeting multiple mechanisms of action. And this is, the area in which, I think research focus, should happen. And if anyone has any questions, I don't know, Sonia, if we're going to hold them to the end, or if you have any questions at this point, then if Sonia says it's okay, then chime in.
Yes, we're going to take 3 minutes worth of questions, and then we'll move on, and we'll have another short question period at the end of the call. I believe Kate's going to open it up for questions now.
Hi, yeah, so all can submit questions. On the Zoom screen, there should be a function for chat. If you click chat, and then you can select Sonia's name to send the questions over. I had 2 that were actually emailed to me, so I can start with those. One question for the patients was, when you talk to your healthcare provider, what can they do better to give you back a sense of control?
I think just asking us is incredibly important. You know, I'm a doctor, and I had to ask my oncologist about a trial, and he then poo-pooed it. By the way, he's no longer my oncologist. The people I'm seeing now, that was one of their first questions was, have you participated in a trial, and would you like to participate in a trial? So what clinicians can do better is to ask us what we want. Some patients just might want to be comfortable and may not want to be terribly aggressive, and some patients might want to do everything, and I think that's super important to ask that question. What are your goals for this treatment?
Thank you. The next question I see here is, do you see a need for research that's focused on addressing quality of life outcomes such as fatigue, pain, and anxiety?
Hell yes. There can be the best treatment in the world. There could be a treatment that you could tell me, this treatment is guaranteed to give you 5 years. But in that 5 years, you're going to throw up every day. You're going to have constipation to the point of needing a stick of dynamite. You are going to have pain, but you're going to live 5 years. You know, for some people, that might be worth it. For others, it'll be why? There's no quality of life. So I do think quality of life measures are exceedingly important to the patient population and should be addressed.
Great. So in your experience, if as a patient you participate in a trial, do you have to stop your current treatment?
I have not participated in a trial, and unfortunately I may not ever be able to, because of my previous treatment regimen will probably render me ineligible for trials, despite the fact that I've never had a treatment failure. But most trials today require a 28-day washout period, which means that, you know, you usually enter a trial. Some people will enter a trial when they're first diagnosed. Many others will enter a trial when they're having progression. So you've had progression. You now must stop your current treatment regimen and be on absolutely nothing for 28 days. There are people that have died during that washout period. In the real world, it is malpractice to stop a treatment for 28 days before going on to the next treatment. So trials should reflect the real world. 28-day washout periods, while they may have some nebulous benefit in terms of the pharmaceutical company, it's not how your drug, when it's approved, is going to be used in the real world. When my Aromasin fails me, they're not going to say, hey, stop this for 28 days before we put you on the next thing. They're going to say, here's the prescription, here's the order for the next thing, start it tomorrow. And trials should do the same thing.
Okay,
we have time for one more question, and then we're going to move to our next panelist, and then we'll come back to any questions that we miss at the end of the program.
Okay, I'll do one that I see frequently from many patients, and that is, what is the best site or resource out there to view questions that you can use to ask your oncologist that are metastatic focused, not just breast cancer questions? Is there that type of resource?
So I think there are a couple. I think MetaVivor is an excellent resource. So metavivor.org. There is not only information about the research that they're funding, there's also information about the disease itself. And the second one is the Metastatic Breast Cancer Network, so mbcn.org. They provide a lot of information. And then the Metastatic Breast Cancer Alliance has a new clinical trial finder that is focused on metastatic breast cancer. And off the top of my head, I don't remember the URL for that. But again, it's a way to search out metastatic breast cancer specific clinical trials, a little bit easier than clinicaltrials.gov. I've been a beta tester on clinicaltrial.gov's new forthcoming website, which is going to be a lot easier to navigate than the current one. But those are 3 resources, I think, that are invaluable to the metastatic community.
Okay, super. We are going to move to our next panelist just for the sake of time. And we have with us Marina Kaplan. She is a PhD. She is an advocate for MetaVivor. She's a metastatic triple negative patient. So I'm going to turn it over to Marina.
Hi there. Thanks so much for having us. I think this is incredibly important and absolutely wonderful, that you're sort of directing the research based on our input. So, gosh, just reflecting back to my diagnosis, it kind of felt like one day I was this ordinary average person. I was a wife, a mom to 2 gorgeous girls, a researcher at a children's hospital in healthcare delivery science in a pediatric setting. And my life was just sort of humming along merrily. And it feels like suddenly the next day I was a cancer patient and everything changed. My entire life would never be the same again. I didn't know a whole lot about cancer previously, and suddenly I know much more about cancer than I'd ever want to know. So I was diagnosed with, initially I was diagnosed with stage 2 triple negative breast cancer in October 2011. I had a sentinel node biopsy, and that was clear. So I sort of felt fortunate that I had, no node involvement, but of course I was extremely worried because my diagnosis was triple negative breast cancer, which is really, really aggressive with a very poor prognosis. But got treatment, got chemotherapy, radiation, had surgery, and my life started to hum along as it kind of had been previously. And I also had this kind of fighter mentality. I was going to kick cancer's ass to the curb. I actually had a blog like that. And as time passed from my diagnosis and treatment, I started to feel more and more relieved, knowing that triple negative is so aggressive that, it hadn't come back. But then in May of 2014, I was diagnosed with metastatic triple negative breast cancer. And that was a really crushing blow. Actually, with hindsight, my symptoms, I had bone mets. My symptoms of bone mets, the pain, had started in December of 2013. So it's pretty obvious that the bone mets had probably been there for an awfully long time. Living with metastatic breast cancer has been kind of like a roller coaster. It's a roller coaster none of us wants to be on. Mostly my life has been fairly good. I've had very good quality of life. But then, of course, there are those days of pain and fatigue and nausea and throwing up and the hospitalizations. And of course, there's been a good number of frightening experiences, like the time I got septic from an infected port and almost died, the time I had a lung biopsy and it bled, and that was a real mess. So life is sort of ups and downs, I have to say, but I really believe super important. And even though I'm just one person, I really have value. So to all researchers out there, to all doctors, I want you to know that each of us feels that even though we have a metastatic disease, even though it's terminal, our life is super important and valuable to us and our families and our friends. I'm a huge advocate for clinical trials. I've actually been on 4 different clinical trials. One was when I was a stage 2 breast cancer patient, and I've been on 3 different phase 1B clinical trials as a patient with metastatic disease. 2 of those have been different combinations of immunotherapy drugs, and one of them most recently has been an antibody drug conjugate trial. I have failed of these trials, I got progression on all of them. For one of these trials was at my home cancer center here in Jacksonville, Florida. But for the remainder of the trials, I've actually traveled to the locations, which is pretty arduous, but I believe it's super worthwhile to take part in clinical trials. I've also been in a number of different chemo combinations between trials. So while I've been looking for trials, then I'll go on a chemo. Can you still hear me? I just got a message that I was off. Am I back on?
Yes, I can hear you now. It seems the connection seems a little funny, but yes, we can hear you now. Okay, good, because I've got a message saying it's cutting in and out. It was for a minute. Okay. So in terms of barriers to engagement, what I've found as a patient, I feel that like engagement in clinical trials is super important. So I believe that ideally at every staging appointment that you have with your oncologist, there should be a list of clinical trials that are available to you in terms of your histology, your stage, or the molecular profile of your tumors or your circulating blood. That to me would be ideal. And that has actually never happened to me. I've always had to seek out the clinical trials that I've entered, unless they happen to be at the cancer center where I'm a patient. And that doesn't happen too often. In fact, that's only happened twice in my life, that my oncologist has said, listen, we have this exciting trial here, and you qualify for it. So I've always had to seek out my own trials. I'm not going to repeat everything that Kelly said, because Kelly made some amazing points about the barriers to engagement in clinical trials. But I did want to just point out, in terms of the 28-day washout, I feel like just running a patient's PKs might help with that. Figure out, sure, this patient just came off of carboplatin, but run their PKs every couple of days and see, how much carboplatin is still in their system. And surely there's got to be a way of controlling for that variable. The other huge variable that I think is a barrier to engagement in clinical trials is physicians' attitudes to trials. So Kelly had that experience where her physician poo-pooed her bringing up trials. And I've had that in the past too. So that's a big deal, and that's a very modifiable level that you can make in terms of physicians' attitudes to trials. They need to be much more open to them, and they need to offer them upfront. And the consent forms that Kelly brought up, I totally agree with that. In healthcare delivery science in a pediatric setting, I've done zillions of consent forms, and most of them are at a really super easy reading level. And when I started going into clinical trials as a patient in cancer, getting access to cancer clinical trials, it was really hard for me to read these 50-page consent forms. So I really feel like something needs to be done about the consent forms. It's a huge, huge barrier. The other barrier I want to mention is the disparities in access to and enrollment in clinical trials. About a year ago, I was contracted by ASTO, which is the Association of State and Territorial Health Officials, to research modifiable systems level barriers in care that contribute to disparities in breast cancer mortality. And disparities at all levels are depressing, but the disparities in access to clinical trials was absolutely staggering. So I feel like that's an area that needs to be addressed. So can we have the next slide? Okay, one of the big priorities that I feel are important for research, and Kelly already touched on this, and I'm not going to repeat what Kelly said, but essentially genomically driven clinical trials that are using the molecular
Marina, you cut out again.
Yeah.
Can hear you now.
Okay, I think I went off and now I'm back on. Am I good?
Yes, I can hear you now.
Okay, great. So as a patient with triple negative breast cancer, this is particularly important to me because I feel like triple negative is just a bucket of what my breast cancer is not. It's really not telling anyone what my breast cancer is. And I sometimes feel like the mutations I have aren't even like breast cancer. So to me, it doesn't matter where the cancer originates, what organ it originates in. To me, it really matters, what the genetic makeup or the molecular profile of my tumors is. Oh yeah, we're back to the right slide. Thank you. So I feel like this could benefit patients in terms of what drug combinations are already out there that could work for us. It could help researchers understand the mechanisms of drug resistance. And essentially the most important thing to a patient is that it could be more effective and efficient. So instead of the current kind of blast them with anything that could work approach that has a host of side effects, precision medicine offers for us patients perhaps a shorter duration of treatment and a better quality of life. So I'm all for that. But there are some concerns that we patients have. First of all, there's, I think, a lack of standardized genomics testing. There are multiple different organizations out there that offer it. There's some overlap between the different organizations. There are some differences, and it's hard to choose, who do you go to for your genomics testing? And that kind of makes me a little cautious and skeptical. They're all appear to be for-profit organizations, and which of these are most likely to return valid and reliable results and profiles that are actionable? And the other thing that I'd really love to see is, which of these most consistently and effectively match us with trials and treatments that are appropriate, and do that on an ongoing basis, not just once and done, you get your profile, they tell you what the actionable results are, and then they're done. I would like to see an organization, and perhaps it exists, that keeps us up to date, sort of sends me an email, hey, based on your mutations, this trial has just come up and is available to you. The other thing that concerns me about the genomically driven clinical trials is that you may be limiting patient access to promising trials based on an inexact science. So, I still feel that genomics testing isn't an exact science, and I might be excluded from a trial that might actually help me based on my genomic profile. And then, of course, there's the small number of participants. Obviously, there are so many commonalities across patients, but there are also so many possible combinations of mutations that I'm worried that each patient with a unique molecular profile will be seen as like too small of an N to bother to study. So that does concern me about genomically driven clinical trials. But aside from those concerns, I feel like that's really the frontier where research needs to go. Okay, can I have the next slide? So Kelly touched on this as well, but I feel that collaboration and moving out the bricks and mortar image that Kelly used so brilliantly is so important. Protocols, bench research needs to be multi-institutional in a way that it's not yet. It also needs to be transdisciplinary, and I feel like data and resources and knowledge needs to be shared across institutions, such as academia, government, and industry, as well as across disciplines. So from the bench scientists to the clinicians and patients and the community. So this sort of sharing across and up and down, I think, is critical, and that's, I think, been a huge barrier to progress. And as patients, we're kind of caught in the middle. I also feel like negative study results need to be shared much more freely. Right now it seems that the only thing that gets published, obviously, are success stories, but there needs to be some kind of repository that everyone can access with their negative study results. So, this study benefited 5% of patients. Really need to figure out who are those 5% of patients and what was it about them that this drug, this clinical trial drug, actually helped them with. They also, I think, needs to be open access to protocols. So I think that across organizations, protocols could be shared. Right now, I feel like it's a very siloed approach, very territorial. Nobody's sharing their protocols. And I think it would be very helpful to us patients if industry and academia and hospitals would share their research protocols. I also think there's a huge amount to be gained from sharing lessons learned or more qualitative type observations. So, the data is available to researchers, and that's helpful once it's published sort of 5 years after the trial has ended. But qualitative information, I think, is extremely important to share. So those little things that aren't necessarily hard data, but really explain the numbers. I also feel like we need to study exceptional responders, and I know there's a bit of movement in that area, but there may be some kind of key to really effective treatments in looking at exceptional responders. What is it about the profile, of their tumors or their clinical outcomes that could inform further study? And I always would love to see a trials matching service that is more, uses artificial intelligence more effectively. I know that there's been some efforts with Watson, and that hasn't really been terribly successful yet. But I feel like it's got to happen. Just like Kelly said, Amazon has got this down to a science. I do a little search, and they know exactly what bedside table I'm looking for, and they send some suggestions. I really feel like trials matching can be as good as or better than Amazon. And I think that's it. Do I have another slide? Nope. And don't know if we have time for questions, or do you want to just have questions at the end?
We're going to go ahead and take 3 minutes of questions. So please feel free to use the Q&A function or your chat function to send a question. Okay, we have a question. When saying trials matching using AI, what does AI mean?
Oh, I'm sorry, I shouldn't use that acronym. Artificial intelligence. So essentially, taking all the data that my oncologist or my several different oncologists may have about me, in terms of what drugs I've taken, the histology and the stage of my cancer and my mutations. So taking all that information and searching out trials using that information. So just as a thinking person can do it, a computer can do it super easy and much faster.
Is PK the M2 PK tumor marker? I've not heard of this marker before.
Yeah, sorry, PK is, I was using it not as a marker, but as the pharmacological characteristics that are in your. So whenever you're in a clinical trial, they always do the PKs. Can you hear me?
Okay, now.
Okay, so PKs, I was just using it in the context of the amount of a particular drug that's still in your system.
Okay.
Not as a marker.
Marina, are you using PK as the abbreviation for plasma kinetics?
Yes, thank you. That's the word. So yeah, my lay interpretation of PK is just how much drug is in my system. And I feel like if we test that, instead of making us wait the standard 28 days, we'll know, okay, there's a tiny bit of carboplatin still in this person's system. We can go ahead with the clinical trial.
Okay. I participated in genomic testing, but was told that breast cancer oncologists only use 5 of the more common or better known genomics, such as BRCA 1 and 2, or P1, PI3K, etc.
I don't know. I feel like that more and more clinical trials are becoming available depending on mutations that are beyond the sort of the standard, the big 5. The big 5 may help to inform standard care, and oncologists who like to, use like NCCN guidelines to tailor their care for their patients. But sometimes if you have an oncologist who thinks more outside the box, they'll actually go to bat for treatments that are outside of the standard NCCN guidelines.
Can I just comment on that also real quick? So there are panels that have more of the top 5, and it's depending on your disease and what your oncologist wants to use, they may use the different panels. A larger issue is we can test for all 2,300 genes in your genome, but what information is that actually going to tell us? So there are metastatic breast cancer panels with 67 genes on them, but we actually don't know. There's very little data on what the genes in there, what a lot of them do. So some of the more well characterized that they're saying are the top 5 that have been studied really well clinically are on there, and I think they may be more important because we can actually take action against those. We understand that they have a role in driving cancer, but on some of the other gene panels, some of the genes, we actually don't really even know what their functional role is driving metastatic breast cancer. So being able to detect it and knowing that it's overexpressed, say in patients, is helpful, but what does that even mean clinically? So is it worthwhile paying to test for more genes if there may not be a clinical action? Okay,
this is going to be the last question.
Yeah, can I just actually second that, because I've had 315 genes tested, and of those, only 4 of them have therapeutic implications, and of those 4, only 1 has an FDA-approved therapy. So I just wanted to second what you just said.
Okay, thanks so much. What is your view in asking patients to participate in large genomic screen when there are very few actionable mutations in terms of treatment? What is then the point considering the expense?
You know what, that's exactly what we were just saying. It is expensive. It's for for-profit industry. You can have hundreds of genes tested, only a few of them are actionable, and even that is an inexact science. I did it personally because I like to collect as much information as possible, but it's not for everyone, especially at this point, until it becomes more of an exact science. And that's why I feel it's a research priority. From a research point of view, this science needs to be further developed so that the mutations do become more actionable.
Excellent. Thank you so much, Marina. We're going to move on to our next panelist, which is Patricia Wu. She is a doctor of education and an educator and administrator in Los Angeles. She was diagnosed with MBC in her early 30s. Patricia, I'm going to turn it over to you.
Great. Thank you. Thank you so much for everyone for joining us and hearing our perspective. To tell you a little bit about what it means to be living with stage 4 metastatic breast cancer, for me, my path with cancer started with DCIS. I was diagnosed at the age of 30, right after I got married, with DCIS, and was told that, all I needed was surgery and I was on my way. And I understand that my experience is very abnormal, but I went straight from DCIS to stage 4. And so 2 years after my DCIS diagnosis, I learned that I had metastatic disease in my bones. I am now currently on my third line of treatment. And I always described life with MBC as holding on to hope. It's every single time I have to have a new treatment, I am hoping and praying that this treatment is going to last as long as possible and be able to control the tumors in my body. But I understand that the current state of the situation is that one day there will be no more treatments left and it will be time to say goodbye. And really, I hope that we're able to continue to have research in order to change that, in order to change what it means to be living constantly wondering when the next shoe will drop, or, you know, when I'm going to need another treatment. One of the stories that I share about what it means to live with metastatic breast cancer is that even something as simple as going grocery shopping. I picked up a can of corn the other day and I noticed the expiration date was sometime in 2018. And I can't help but in that moment just being reminded that I've actually passed my expiration date. I'm fortunate to be 4 years out from my metastatic diagnosis, which is longer than the median that is being reported. And again, you know, really want to be able to change that. I also hope to be able to change the narrative and be able to have voices that are more diverse than we currently have. My understanding is that clinical trials right now are represented 83% by white women. And so for me, being young and being Asian American, it was also just very surprising that I was unable to find other patients that looked like me. And that makes me wonder, you know, how might that data be different if it is different? And really would urge us to continue to have that dialogue in capturing all voices. If we can go ahead and go to the next slide. Hopefully, my story and introduction begins to illustrate that this is a community, the MBC community. It's raw, it's passionate, it's a very dedicated individuals. And the lack of time, it is both a drive that makes this, you know, the number one thing in our face every day. And it also can make collaboration challenging because any part of advocacy I'm a part of has to be balanced with my treatment, and that treatment has to come first. So there are times that I will end up missing meetings or other obligations because I have to prioritize my treatment. Right now in the metastatic breast cancer community, I don't feel there's a singular focus. And I think that is both an asset and it is also a challenge. It's a challenge because there's a lot of different initiatives happening. It's also an asset because we need to be exploring this from many different sides, including treatment, including quality of life, including access. I have seen in the recent couple years that organizations such as MBCC, as well as just other online registries, are really facilitating connection between advocates and researchers. There's a lot of places where we're able to register and be able to be connected with researchers who want to work with advocates and advocates who want to be a part of the research. I do feel that on both sides, we're all still learning our roles. And having been involved in a couple different grants and a couple different projects with researchers now, it is very different in how it is that I'm working with each group. And I think that there's just still a learning process. I think it would be helpful if there were clear guidelines on what the role could be in order to provide some guidance. And also, I have found in my own experience that when I've been on teams that has had a practicing clinician, someone who is an MD, and I think Kelly spoke about this earlier as well, versus having only PhDs, I think that definitely helps to facilitate the conversation and has somebody who can help to sort of translate for me. If I can go to the next slide, please. In terms of thinking through what are some of the research priorities, I would really like to emphasize or really speak to just drug resistance. Again, as I think the previous panelist has said, I agree with the things that have been said before. What came top of mind to me was really thinking about drug resistance, really being able to understand why our tumor cells do grow a resistance to drugs, and how that information might be able to help us stay and maintain on a drug longer, figure out the sequence of treatment, and or come back to a drug that was at one point resistant, but we may be able to change that. I think that has to start with the medical research to be able to understand the mechanisms and why it is this is happening, what is driving that drug resistance. I would hope that that research would eventually translate to having guidance on if and when a drug can be used again. So for example, I've been on 3 lines of treatment, and each one I've eventually had progression on. I would love to be able to understand from a research standpoint if there's a point where I can go back to that first treatment and hope that it might be useful again. I think that would be a huge step if we could change what is currently happening with drug resistance. It would be a huge step in making MBC a chronic versus a terminal illness. I also would be very interested if there is any movement to be able to have clinical observational studies to really determine if the sequence will affect progression-free survival or overall survival. For example, recently, in the last couple of years, Ibrance, and then very recently, I think it's pronounced Kisvai, is both been approved for CDK4/6 inhibitors for estrogen-positive breast cancer. Abemaciclib was also approved, I think, just a couple weeks ago. These are 3 drugs that work very similarly on a molecular level. And I think it would be wonderful to be able to talk to patients to see how it is that they have experienced the progression, because a lot of these are clinical trials. So for example, I have currently been on abemaciclib, but I have not been on one of the other 2, and I may move to one of those. So how can we go back and collect that data to say if a patient has gone in a certain order between these 3 CDK4/6 inhibitors, did that order make a difference in the progression-free survival or the overall survival? And then that can quickly translate to extension of life for patients that all have the same options. Along the same lines, also thinking about like the clinical trials are very specific, and I understand that they are specific in order to allow for clean data, if you will. But I'd like to understand, so if something is ER positive, is that equally effective for somebody who is HER2 positive versus HER2 negative? A lot of the CDK4/6 inhibitors, those clinical trials were all done on HER2 negative breast cancer, but it is possible that they would have the same effect on HER2 positive. I myself am HER2 positive, and the trial that I'm on for abemaciclib was for HER2 positive as well. And so I know I can only speak for myself, and that's one data point, but it's been effective for me. And I'd like to be able to understand for all of these drugs, like what are the options? I think other subgroups that I didn't get a chance to list on my slide, but also thinking, are we seeing the same effects for patients who might have inflammatory breast cancer or who have different subtypes of breast cancer? Are we still experiencing the same things? Because so much of our conversation is about hormone positive or HER2 positive. Thank you so much. I think at this point we now transition to questions.
Our first question is, in the same line as the required 28-day washout, almost all trials require an ECOG performance status of 0 to 1, sometimes 2. What about patients who aren't in excellent, very good health? Are they being denied access to potentially efficacious drugs?
I agree with both of the panelists who spoke before me. I think we need to find ways to revisit that 28-day washout period. And I think in addition to that, I would also say I would really want to revisit the guidelines for having new biopsies, new samples, especially biopsy samples. For the clinical trials I've been on, I applied for a trial, was denied, and then had to apply for another trial. Because of that, I actually had to get a second biopsy. And every biopsy is a risk for me for, you know, all the different side effects, including infection or, you know, any type of other situation that would occur. So in addition to just the washout period, I would agree with that, strongly agree with that, and then also bring into the conversation the need to collect specimen and how we can rethink that.
There was some questions about was Kisqali the medication that you were talking about, and that was a Verzenio drug that's just been FDA approved for Lilly. Okay, so the next question is, so you get it from the doctor already, even though it was just approved? Talking about Verzenio.
For me, I received abemaciclib as a part of a clinical trial. So I have been on abemaciclib before it was FDA approved. And I think in the comments to everyone, Kelly Shanahan, thank you so much, Kelly, has listed kind of the drugs that I mentioned with their brand name as well as their clinical trial name.
Okay, and this will be our last question, so we move to our next panelists. I think that multiple modalities should be used. I recently heard Dr. Buchholz, radiation oncologist, discuss oligometastasis and using SBRT. SBRT could be used alone and in conjunction with immunotherapies. It may push us out a few more years until more treatments are available. And the last question is, what about blood biopsies?
For those questions, I have to first just acknowledge that I don't know a ton about, I don't have a ton of information. I don't feel very able to speak to either one. What I do know is that they're emerging options, and I would hope that we would continue to research them. I know that I've read some things about blood biopsies as a up and coming hope to move away from having tissue biopsies. But to my knowledge, it's still something in development. I would personally love to be able to see an acceleration of that, but I would love to see an acceleration of all types of research.
Okay, excellent. Okay, we're going to move on to our next panelist. Thank you so much, Patricia. And again, we'll come back for a couple more questions at the end of the program.
Can I
Leslie?
just real quick on that point, I just want to encourage everyone to attend webinar 3, where 4 oncologists will be present, because I think a lot of the questions coming up about blood biopsies, current treatments, they're going to be discussing current and future treatment options for MBC. And so a lot of things that are coming up, in addition to why do oncologists not want to put us on a trial until we've progressed, why can't we be more proactive? I'm just encouraging everyone to save these thoughts if they're not answered here for December 13th.
Thank you, Kate. Our next panelist is Leslie Falduto. She is now a retired RN. She's a wife, mom, neonatal intensive care nurse, and a 2.5-year METAvivor volunteer and advocate. She was diagnosed with metastatic breast cancer 3 years ago, with an initial breast cancer diagnosis 9 years ago. I'm going to turn it over to Leslie.
Hi, can everybody hear me okay?
Yes, thank you.
Perfect. Yeah, I was diagnosed with stage 3 breast cancer at 31 years old. I was married. We had a son that was almost 2. I had done everything that I thought was right to decrease my risk for breast cancer by not smoking, staying active and fit, having my first son before the age of 30, breastfeeding, everything you can think of. And I found a lump in my left armpit while showering. The mammogram and ultrasound did come up negative for breast cancer. After an aspiration biopsy for my axillary node, the physician thought I either had GI or breast cancer. And after a breast MRI, they discovered that I had 3 tumors in my left breast. I have no family history of cancer, and I do not have the BRCA genes. After my core biopsy, they found out I was triple positive. My PET was negative for METs. And like some of you had mentioned, I thought, oh, thank God, I can beat this. It didn't spread. So I underwent dose-dense chemo, AC and Taxol. I had a bilateral mastectomy with reconstruction. I had Herceptin for over a year, tamoxifen, chest wall radiation. After all of my treatment, I had a clear PET scan. I went on living my life. I trained and ran into half marathons. I participated in 10-mile runs, multiple 5Ks. Again, did everything I was supposed to do, saw my oncologist every 6 months. After almost 3 years of seeing my oncologist and being quote unquote healthy, I did get pregnant and had our second son. It was a very uneventful pregnancy. And then almost 6 years to the day that I found the lump under my armpit, I had a tonic-clonic seizure while working in the neonatal ICU. The initial brain MRI showed what doctors thought was a meningioma. And when they went in and did the cranie, they found out that it was, again, triple positive breast cancer in my brain. After the cranie, I had SRS radiation to my brain, and all my physicians kept telling me, you're healthy, there's no way this is anywhere else in your body. And I kept saying, I think you're wrong. It's in my brain. It has got to be someplace else. And lo and behold, they found that it had spread to my lung and to my spine. And once again, I had to undergo chemo, Taxotere this time, Herceptin, Perjeta, and aromatase inhibitor. I did have my ovaries and fallopian tubes removed. And I had been no evidence of active disease for nearly 3 years, and I recently had a slight progression in my lung, so they've tweaked my treatment. Living with Mets has been a challenge, not just for me, but for my entire family. And a lot of people don't understand that. And that is also a grieving process of your pre and post cancer life, mourning the loss of what you used to be able to do without pain or fatigue that you can no longer do. Appointments, scans, infusions, more scans, well visits, because you still have to have those. My children's sports and activities, my husband's job, hobbies, everything has to be worked around. My energy levels are depleted most days, and I try to stay active for myself and for my family. And I try to volunteer at my kids' schools and everything else. I guess we could go to the next slide. So the key issues for metastatic breast cancer. There seems to be a lot of barriers to open exchange with researchers. I feel that if there is a way to create a platform where researchers could trade ideas and data they have discovered along the way, that it could possibly shorten the time it takes to get new medications approved. And I hope that if there was something created where researchers and scientists could get together and could share this information, that they could use this to their advantage to expedite change in metastatic breast cancer treatments. I feel that if they had this time, that they could find more drugs, more medications, things that were less toxic, and could help us along the way in all of our treatment time. Again, that kind of goes into our top-down research. There's a lot of talk in the metastatic breast cancer community about top-down research, meaning that they start with the metastatic breast cancer patient for trials and treatments. And my understanding is that all trial drugs are first tested on metastatic breast cancer patients, and that they have had other treatments and have failed. If medications are being studied in the metastatic breast cancer patient or community, why are we not seeing changes in the mortality rates? The number of men and women dying from this disease has not changed in over 40 years, and there's been little to no change in the front line of chemotherapies, and a slow change in immunotherapy departments. I feel that there's a lack of research also in side effects of long-term treatment in the metastatic breast cancer patient. There are some men and women that are living beyond the 12 to 36-month life expectancy, but with that, you have to continue to take medications that are toxic to other organs. And now you're having to go in for MUGA scans or echoes, getting your liver enzymes checked because it's toxic to your liver, your kidneys. Maybe there needs to be some more time also spent in researching how effective lower doses may be, or alternating medications to reduce toxicity of the standard dose of chemotherapy, immunotherapies, aromatase inhibitors. And maybe that would be more beneficial to the long-term survival and our quality of life. Our quality of life should be just as important as quantity. The inclusion in trials, I believe that there needs to be more inclusion of metastatic breast cancer patient with mets to the brain, like myself, to clinical trials. I am removed from a lot of trials due to my met to my brain. I feel that if you're having mets to the brain and progression systemically, maybe that should be something that is looked at together to hopefully decrease the chance of having mets to the brain, which in my opinion is the most detrimental. You need your brain to do everything. And eliminating brain mets patients may unknowingly take away some sort of treatment that may work on either the early stager or the metastatic breast cancer patient. Metastatic breast cancer therapies or medications could be further along by collaboration among researchers, scientists, and really examining new drugs and their long-term effect on the patient by including all MES patients in research. I don't know of any metastatic breast cancer patient that doesn't want to be included in research. we all want to contribute in hopes that we can find some long-term solutions to the short-term life expectancy with metastatic breast cancer research. And, going back to what everyone else had kind of stated before me, and other things that I feel that are important are patients need to be their own advocate. That is so important in all of this. And that doctors, please advocate for your patients. Most patients have no idea what their options are, what they can do, how they can be involved in research. If it's small or large scale, involve your patients. Don't judge them based on their diagnosis, education, or social status. And don't leave out the metastatic patient. Keep us open to research. And one other point really quickly that I wanted to make was with the insurance and covering patients that are on studies for additional treatments or side effects that they may have during research trials. If their insurance will not pay for them to get additional medications or treatments that they need for side effects for a trial drug, you lose patients because it's a financial burden. So with that being said, I feel like I kind of spoke quickly, but I feel like we're on a little bit of a time crunch. If there are any questions.
Okay, we are going to take some questions now. I think that the multiple modalities should be used. I think we've already covered that one. Sorry about that. Let's see.
I think for the most part, we have comments. There was one comment I want to acknowledge, and that was about including more men in clinical trials. And I just really want to acknowledge them today because male metastatic breast cancer absolutely does exist. And we're very much working to include male MBC patients in our webinars and conference as well, including one oncologist in the webinar 3 in December who specifically treats male metastatic breast cancer. So I just want to say we agree we need to allow more men in there and acknowledge that metastatic breast cancer isn't just a female disease.
Okay. And for Leslie, did your oncologist encourage you to participate in a trial after your brain met diagnosis, or did you have to ask?
I had to ask. I asked if there was any trials that I could participate in, and she said that I had to go through the first line of defense, and if I was stable after that, then I wouldn't qualify for any trials.
Relative to clinical trials and translation to the clinic, phase 1 trials seek to discover the maximum tolerated dose, which is often used once the drug is approved. Phase 2 trials should focus on minimum effective dose. We've seen several instances, such as Xeloda, which is capecitabine, whereby reduced dosage and or less frequent administration is efficacious and carries less toxicity. So that's kind of a comment.
I think for the most part, we just have comments in here now. In the interest of time, we probably should just conclude. We're about 15 minutes over.
Okay. If you, as Kate mentioned, we have 2 other webinars in the series, and we strongly encourage you to complete your survey. It's only 4 questions. Submit that survey because that's going to be the foundation that will lead to discussions on MBC research priorities. We really need your voice. So we would love to hear from you on that. Please participate in the next 2 webinars. And I just want to thank all of the time that was spent by our panelists, Kelly Shanahan, Patricia Wu, Marina Kaplan, and Leslie Falduto. And thank you so much for the time you've spent today and for your advocacy for metastatic breast cancer. Kate, do you have anything?
Great. Lastly, I would just say these webinars are made possible by grants, but also through Metastasis Research Society membership, which now is not just for clinicians and researchers. We've opened to patients as well. If you're interested in joining that, it's metastasis-research.org, and there's information on this project as well. You'll also find that we offer a directory for patients to participate in that does not require membership. So if research interests you, you would like to offer grant support, help facilitate patient-centered projects being developed, work with clinicians and researchers in that way so that your voice is included in the research process, we encourage you to participate in that directory. Again, you don't have to pay for membership to be in the directory. It's absolutely private, and it's organized by myself. So that opportunity exists if you want to continue to be part of the research process. And I think that is all.
Thank you all so much.
Thank you.
Thank you.
Bye, everybody.
Bye-bye.
Bye.